one of the things that we have to kind of think about is, we talked about all these different treatments. And so the bone marrow toxicity, docetaxel causes bone marrow suppression. PARP inhibitors cause bone marrow suppression. Pluvicto causes bone marrow suppression. Is this something that everybody thinks about and in terms of sequencing or any kind of pearls that you do in your practice?
I think it's incredibly challenging, and I think there are patients you expect to have, maybe great tolerance of a medicine, and they don't, and it's much worse than you thought, or vice versa. You expect someone to do really poorly, and they actually do pretty well. So I think always being mindful of your next treatment is helpful, so you can time things correctly and try to mitigate and prevent just sort of severe drops in their blood counts before you move on to the next thing, and transfusion support and other things as you need to is important.
Absolutely.
I agree. I mean, it's a really a difficult, challenging situation when you have someone BRCA2 mutation, for example, and then their bone marrow is shot with a hemoglobin of 8. And I mean, it's a tough decision to have, and then you are stuck whether to pick that PARP inhibitor, for example, in that case or not. And sometimes I've also seen cases where patients who have had prior chemotherapy or let's say Pluvicto, if their bone marrow is shot, you have to put on your hematologist's hat and start thinking whether it could be MDS, because these patients are elderly, if they could have leukemia or something else happening. So I have a patient who we diagnosed with acute leukemia after prior AML after Pluvicto treatment.
Wow.
So, I mean, you need to keep thinking into these considerations. I mean, there is a small risk of leukemia developing with PARP inhibitors as well. So
sure.
Patients hear about that, they start to question they really want that treatment or not.
Yes, that's a great point. Beta particles, I mean, it cuts through the DNA, causes DNA damage, and leukocytes, lymphocytes, I mean, boom, it could take off. And so PARP inhibitors, those are higher risk of MDS. I mean, I think it was mostly ovarian cancer patients that receive platinum and then receive a PARP inhibitor. But if we have 2 cell lines down, like grade 3 thrombocytopenia, platelet 40,000 for 3 months, right? Anemia, hemoglobin less than 8, bone marrow biopsy.
Yeah.
We don't want to miss that.
Exactly.
All right, so now we're going to kind of switch to our patient case. So we have this is a real case that we want to kind of share and see how the panel would do here. So we have a 62-year-old patient diagnosed with metastatic hormone-sensitive prostate cancer. They did conventional imaging, CT scan, and a bone scan. Bone scan showed 3 lesions, all in the lumbar spine. And so patient, this is newly diagnosed. So, so how would you treat this patient, when they first come into your practice, because this is like low volume metastatic hormone-sensitive prostate cancer?
So do I have access to a PSMA? Yeah. First thing I would do is get a PSMA. If that amount of disease was confirmed, I would consider them for oligometastatic treatment in addition to doublet therapy, potentially. But again, as you mentioned, trying to limit the window and not indefinite drug.
Because you don't want to miss, as right now we don't run into this issue because most of us are doing PSMA scan, but Oriole studies actually showed that if you miss, you don't treat SBRT, PSMA avid site, and just treat the CTs, the conventional sites, the progression-free survival is less. So all PSMA sites, if you're going by SBRT route, should be treated based on PSMA PET scan. Now, definition of oligometastatic has completely changed because the definition was unconventional, and now we are using the same definition but using a different scan.
So like, let's go by your example. Let's say we do a PSMA PET scan, and now we have 7 lesions.
Yeah.
And so, Ryan, what are your thoughts there? Instead of 3, you have 7 with the PSMA PET.
Yeah, if they're not symptomatic lesions, I would probably not consider them for, directed radiotherapy to those sites. And you look at their other dynamics, their doubling time, their genetics, their PSA, their Gleason grade, and doublet therapy primarily, but I would consider referral for chemotherapy if they had another high-risk factor.
Absolutely.
Yeah.
Zin, any other thoughts on this, on our case here?
I will completely agree with Dr. Ryan. So, right, so 7 lesions cannot meet the criteria for the high volume, right? So, however, again, the definitions kind of based on the bone scans, right? So with the bone scan, it's not being the criteria for the high volume, just from the PSMA. But right, so molecular testings, and then if they have a aggressive underlying P10 or RP3 or so things like that, then I guess we could consider adding the docetaxel and then giving triplet therapy. I think there's a real-world study kind of looking at whether the number of sites matter. I think from the real-world study, I think the more than or equal 10 METs have a better benefit with the triplet than the less than the definition of the high volume disease.
Yep, great points. Yep.
One thing I would also add, I mean, if you have a case dealing with oligometastatic based on conventional imaging, I mean, you should always think about treating the primary prostate with radiation, right? I mean, there is a survival benefit when you treat prostate primary disease in that case.
Yeah, like 0.68, so there's a 32% reduction. And that's just on radiation alone with the continuing with. Now, I think one of the controversies there is, I think when you look at the, I guess a Stampede study where they didn't show overall survival, but the patients didn't have these, like bladder, like hematuria, like these patients with like PT4 when they have like complications from the cancer in the bladder. Is that something that you see a lot, Ryan, when you have the cancer, because of the cancer causes blockage in the bladder and all these complications?
Absolutely, as well as obstruction of the ureter.
Yes.
They need, stents. They're often not able to be put in from below. You end up with a nephrostomy tube. They're on blood thinners that have to be paused. So
yes.
I think local control is really important. And it may not be important today.
Yes.
But it's important in their journey later.
Absolutely. And that's why even though there's an overall survival in one study and the other one doesn't, there's definitely an improvement there in terms of blockage and obstruction. And maybe for some patients that are T4, and if you look at the anatomy where the prostate is, maybe we would consider there's no overall survival there, but to stop any kind of complications for high volume as well. That's something that we might consider, even though there's no overall survival. So, so we'll go ahead and kind of wind down here. I want to kind of go to the panel one by one here. We'll start with Kumar. A lot of changes here in prostate cancer, a lot more changes coming in the next 6 months to 12 months. What are things that you're looking forward to, and what are some of the advances that you're thinking about in prostate cancer right now?
So a lot of stuff we have discussed already, a lot of stuff we have in resistant setting, moving up, incentive settings, especially like Pluvicto and PARP inhibitor. If there's a role, would be exciting to see in next few years how it pans out.
Yes.
And then, new drugs, like we have BiTE T-cell therapies, CAR-Ts, BiTE cells. So those are some completely new class of, medications we are exploring. And they are already in phase 3 trials.
Yes.
So next few years, I feel like we'll have new class of medication, and some of the old class will hopefully move up front as well.
Yeah, great points. Vikas?
No, I'm really excited the way field is moving. I mean, I envision a day where we can personalize treatment for each individual patient. Like we have, for example, in breast cancers, we have ER, PR, HER2, and so many other distant classifications. So in lung with so many different molecular classifications. So I hope that we have enough biomarkers that we can pinpoint who needs ADT and who needs ARP and who needs chemotherapy. So I hope the field is moving in that way.
Great points. Ryan, any thoughts?
Yeah, I think the molecular markers, the testing that's coming, the biomarkers are really exciting and important to help us categorize people. And I really think about trying to de-escalate treatment as much as escalating. But if we had a tool to help us decide who needs which direction, escalation or de-escalation, I think is really exciting. And there's some stuff coming out that I hope will help get us there.
Absolutely.
Yeah, a combination of all three of those things as I'm excited about. I think de-escalation, when feasible, based on biomarkers, would be wonderful. I think watching the field move from drugs that we know work in the resistant setting to the castrate-sensitive setting is always exciting. And with the right outcomes, I hope that'll move the field forward. And I'm excited to see what's next.
Yeah, great points.
So I agree with all the panels, the future direction. Yeah. But I think the high-risk localized prostate population is also very important, right? Because they have 50% chance of progression. And if we can increase the cure chance for those population, perhaps we don't have to deal with all these resistance or treatment options for metastatic. So I wish I would want to see more for drug development to have a high cure chance for the localized high-risk prostate population.
Yeah, I agree with everybody. I think the patients is why we're all in here, to help patients. And some of the medications and some of the studies, like the Aricept study, when you actually have PSMA PET scan incorporated in that biochemical recurrence, that can really help patients. And there's actually a definitive stop in terms of stopping treatment. So that's gonna, and there's a ctDNA in that study as well. So that's something that's gonna really come in. And then also with the triplet and doublet, where we can kind of manage with that PSA of less than 0.2, I think that's going to be huge. And then keeping up with the information. Everybody here loves reading about this stuff, and this is where the science is taken off. So I think it's just great, and it's going to really help out our patients to keep up with this.